Welcome everybody to the webinar. My name is Jennifer Bright. I'm the president of the International Consortium for Health Outcomes Measurement, or ICHOM. Today's webinar is the second in our series of public webinars, and the topic today is the central role of patients in defining health outcomes, how co-creation benefits all stakeholders. This is an important topic for ICHOM. It's been part of our history, and it's certainly a big part of our future as an organization. And in fact, the notion of patient centricity is really part of the DNA and the mission and the reason behind the founding of this organization. So we are very passionate about this topic here at ICHOM, and we are very fortunate to have a wonderful panel today to talk both about how ICHOM operationalizes this concept, but also the work on the part of our partners, on the part of clinical leaders, and on the part and from the perspective of people with lived experience. So we're very excited to have this webinar today. With that, let me just welcome to the screen, welcome to come on camera, Leslie Moody, who is our moderator for today. Leslie is the solution director and heads digital oncology for Varian, Varian is one of many of the partners that ICHOM works with on a global level in our work. Leslie comes to us from her home base in Canada, and she brings a wealth of experience in clinical project management. And as clinical director, prior to joining Varian, she was at the Princess Margaret Cancer Center in Toronto, and she has a long history in focusing on patient-centered outcomes, especially in the cancer care arena. So I know she brings enormous passion to today's topic. And with that, I say thank you, Leslie, for leading us in this conversation, and handing it off to you.
It's an absolute pleasure to be presenting and moderating today. We have an excellent panel that will be sharing their perspectives, each of their unique perspectives on this topic of co-development, co-creation in terms of patient-reported measurement today. As the industry partner, I'm delighted to share why it is so important for us to be partnered with ICHOM at Varian, a Siemens Healthineers company. Perhaps we can move to the next slide. We can jump right in to the following one as well. Unless you come from a cancer background or procurement potentially background in your organization, you probably have never even heard the company name Varian before. We were acquired by Siemens about 3 years ago, and we are now over almost 70,000 people power across more than 70 countries. So seeing all these countries in the chat come in for where you are coming from today for this webinar is just wonderful to see the breadth and depth of the experiences, the organizations, the countries represented. For us, we are the global leader and most well known in the radiation oncology space, but we actually work across a multidisciplinary oncology portfolio. And we're about, over 75 years of experience in radiation medicine. Our home base is in Palo Alto, California in the United States, but we do have offices across the globe. If you can imagine, for us as an organization and an industry partner with ICHOM, we would want to be aligned in our vision, our ethos around patient engagement, co-development, and that is certainly the case. So with over 240,000 patient touch points an hour globally, it behooves us as an important cancer and imaging and multidisciplinary ologies, as we like to say across Siemens Healthineers, to ensure that we take that co-creation, that co-development approach, not only with our most important stakeholder being our patients, but our providers, our organizations that we support with our technology and innovations, as well as the clinicians and scientists that help build the pipeline for our technology and services across the globe. Next slide, please. You can think of Varian Medical Systems basically as the oncology pillar within Siemens Healthineers. And so for us, our our complete mission and vision is to build a world without fear of cancer. We can't do that without important partners like ICHOM and ensuring that we are aligned in our co-creation and our patient engagement at every step of our technology, software development, as well as in terms of our philosophy around care delivery and the way that we work with our partners. It's no surprise, I'm sure, to anybody on the call today, the burden of cancer globally is rising. By 2040, there will be about 30.2 million new cases per year. That's a staggering number, and that's just in the cancer domain. What is really pushing the envelope here in terms of the way that we deliver health services and the way that we build out our technology and services that we offer as an organization is compounding that is that half the world is still lacking access to essential health services. And that includes a significant burden on health human resources, finances, and that is having an impact across the globe in terms of that patient experience. And we need to embrace the philosophy end to end from a cancer perspective around patient-reported outcomes, patient engagement, and a person-centered care delivery model. I work as a health researcher as well out of the University of Toronto. I've done a lot of work in patient engagement, patient-reported outcomes, patient experience, person-centered care policy. And we always talk about patient engagement sort of from three levels, at the macro level, the meso level, and the micro level. And where we're aligned as an organization and industry partner is really ensuring that that level of engagement and co-creation is at all of those levels throughout our organization. I'll give you two very important examples. If we move to the next slide, please. We do work with not only from a radiation medicine perspective, but we do work with our partners with a very important digital engagement platform. We call that Nuna, and Nuna actually means big sister in Korean. And if you think about it, many of you, I imagine, have friends, families, yourselves that might have been touched by cancer in your lifetime. And who wouldn't want a big sister or a quarterback supporting them through their cancer pathway, their cancer journey? And so this is a digital engagement, a way to help patients engage across the cancer continuum, both with portal features, but it also really is a way for us to collect validated patient-reported outcomes, such as the ICHOM sets. And so this is one way that we have built out. We've co-developed this with a patient advisory committee, and we ensure that we are offering not only just a technology and imaging, a patient radiation perspective, but that we actually have software and digital tools to be able to encourage engagement from our patients with all of our enterprise and organization partners across the globe. Next slide, please. Importantly, so we also have a program called Empower Me. So we work with patient advocacy organizations across the globe from a cancer perspective. We also enable patient guides, for a very important one that's very well known across the world in the radiation world is our Cosmo for Kids. As you can imagine, it's typically very scary in many health systems across the globe. Pediatric patients are still going to adult centers for their radiation treatment. And when you're in a pediatric hospital, there's a lot of patient engagement that occurs with parents and children, guardians. And then they move over to the adult world and it can be very scary. So we have an entire engagement program called Empower Me, especially for organizations that might not have the people power to have relevant patient engagement at their fingertips. And so we want to make sure that we can help the customers that we work with that may not be the big cancer centers of the world also have access to credible information, both from an adult and pediatric patient guide, videos, etc. So from us, it really is our ethos as an organization to be ensuring that we have that patient engagement at all levels of our technology development, our software and services that we provide, and just in the way that we engage with our partners and who we choose to partner with. With that, I would like to turn it over to Amanga de Silva from ICHOM that would walk through why we are so aligned as partners with ICHOM from Varian. Thank you very much.
Leslie. So I want to provide an introduction today to ICHOM's approach to patient engagement in the development of our sets of patient-centered outcome measures. So there are several key principles we follow in our methodology that really sets us apart in being patient-centric. Firstly, patients are really integral to the set development process and co-develop our sets with us from the very beginning. Our sets are also defining the outcomes based on the medical conditions to truly capture the impact of the condition itself on the patient's health and quality of life, instead of being centered around specialties or procedures. In addition to the more commonly measured clinical reported outcomes, all of our sets also include patient-reported outcomes and measures so that healthcare providers can really understand patient perspectives of their own health, their functional status, as well as quality of life, which are oftentimes outcomes that are not captured enough in clinical practice, despite really being important to patients in their daily lives. Our sets also contain case mix variables and specified time points for data collection to allow outcomes to be compared both within and across populations to eventually help clinicians and researchers understand, for example, best practices in healthcare to eventually also help improve patient care. And finally, our decision-making processes are very inclusive. They're very multidisciplinary and international to help us ensure that our sets are developed based on comprehensive and balanced feedback that can actually help us address potential disparities in healthcare. Next slide, please. So I mentioned that patient feedback is really central throughout the development process of ICHOM sets, and I just want to go over how it is that we identify and include patient input. So the first step really is in the formation of our working groups, where we start our search for patient representatives to develop this work with us. And we do this through open calls via patient organizations, through our professional networks, as well as through the monthly ICHOM newsletter. And we are actually now in the process of initiating a new set for kidney stones. So if you are interested in getting involved with this initiative, then please do keep an eye out on the newsletter in the next few months for more announcement on how you can get involved with us. Next, we start our set development process with the recruited working group, which involves 7 to 8 calls and surveys where decisions for the set are made. And patient representatives are compensated for their time to ensure that we remove any potential financial barriers to participation. And we also hold separate breakout sessions with our patient representatives to make sure that the direction the set is taking is really focused on the outcomes that are actually prioritized by patients, so that we can course correct if needed with the larger working groups if necessary. This breakout call is also as a check-in with our patient representatives during the research process to help understand what support that they might actually need from us to facilitate their involvement and address any potential questions or concerns that might come up during the process. We also seek external patient feedback during the set development process during a patient validation survey process to capture wider lived experience perspectives on whether the outcomes that our working group includes in the set are in fact actually what is most important to patients. And then finally, patients are included as co-developers and co-authors in the set and are in fact also included as the co-authors in the final peer-reviewed publication where we detail the set development process in full. And we also look for opportunities for patient representatives to be involved in global conferences to disseminate this work. And that also includes the ICHOM annual conferences, which this year is being held in Amsterdam in October. And every year we're looking to increase patient involvement at our conference. And we're very excited for all the patient perspectives that will be highlighted at our conference this year. And we hope that you'll be able to join us. And Jen, at the end of this webinar, will provide a little bit more information on that. Next slide, please. So Jen mentioned that ICHOM has always been very committed to patient centricity since our inception and to the co-development of research with patients. But we've not previously articulated just how we do this to our community. And upon reflecting on this, we've developed the ICHOM Patient Charter, which we launched last year. And this is a document consisting of 8 guiding statements, which you can see here, that outline the rights of patients that are partnering with ICHOM and how we as ICHOM will empower them as research partners. And this framework was developed with input from our patient community as well to really help ensure that it reflects the correct patient priorities and needs. And so we can be very transparent with patients as well who want to work with us of what they should be expecting from us. We anticipate that this charter will evolve with best practices in patient engagement, and as we also continue to receive more feedback from patient representatives who partner with us in our initiatives, so we can ensure that this engagement is actually truly meaningful. Next slide, please. So we're very encouraged by the positive feedback that we've received from patients so far who have partnered with us in our previous sets. Who have felt during the set development process that their voices have indeed been heard and treated as equal to those of clinicians and other stakeholders in our working groups. And this feedback and others that we've received really reinforces to us that we're on the right track. And it highlights the importance of patient-centered approaches to encourage the continued integration of patient perspectives into research and healthcare delivery. And we feel that it also shows that ICHOM can be considered a trusted partner in these efforts by our patient community. Next slide, please. So we're very excited as we think about what's next for ICHOM and as we continue to grow as a patient-centric organization. So some of the ways that we'll look to do this is to really strengthen our methodology to ensure that we have robust patient representation in our working groups, and also to improve the patient validation phase of our set development process so that we can really get as much feedback as possible from our patient community on our sets, so that the final recommendations that are launched can provide as much value to patients as possible. We're also exploring ways of creating materials that summarize our sets so that they can be more useful to patients in their communications with healthcare practitioners, as the current versions of the materials are a little bit more geared towards clinicians. Next slide, please. So I want to conclude by highlighting the ICHOM Patient Partner Alliance. And this is a partnership between ICHOM and patient organizations who really share ICHOM's mission of enhancing patient care by elevating patients as equal partners in their care through shared decision-making. And I just want to highlight that if you are part of a patient organization with this mission, we would invite you to join us in this partnership. And you can learn more about this or learn more about how you can get involved by reaching out to ICHOM at the email address that's listed on the bottom of the screen here. Thank you. And with that, I'm very excited to hand over to our next speaker, patient and ICHOM board member, Kevin Wake.
Thank you, Manga. First of all, I just want to thank everybody for allowing me to share a few of my thoughts as a patient in this process. And I'm excited to really talk briefly about the role that patients can play in defining health outcomes. Before I begin, though, let me just share a brief background on my personal journey. As was mentioned before, I do live with sickle cell disease, as did both of my brothers. However, I worked extremely hard to defy the expectations that my own providers had for me in my life. And I attended and graduated college and had a successful career for 23 years in pharmaceutical sales. I loved my career and I loved how I was helping patients. However, in 2016, I had my second stroke and had to retire unexpectedly due to complications. I thought in my career that I was truly representing patients and their voice in everything I did. But it wasn't until my personal journey shifted to more disease management and patient advocacy that I truly understood the need to further elevate the role of the patient voice in all aspects of healthcare. Healthcare traditionally has been a top-down system where providers dictate treatments to patients and they follow instructions. However, this model often overlooks the unique insights and the experiences that patients can bring to the table. I'm happy to say that today there is a shift where patients are more of they're not just passive recipients of healthcare, but they are more active partners in their healthcare journey. Patients have unique perspectives and lived experiences regarding their health conditions, treatment preferences, and also lifestyle factors. By involving patients in defining outcomes, healthcare providers can better tailor treatments and care plans to meet the individual needs that patients have more effectively, and patients can have more meaningful and relevant patient health outcomes. When patients are involved actively in their care, they are also more empowered, and they are more likely to be engaged and committed in the healthcare journey and ultimately improve outcomes as well. While traditional metrics and measurements in healthcare are important, they may not fully capture the outcomes that matter most to patients, such as quality of life, functional ability, and emotional well-being. Different treatment priorities may also be discovered when you involve the patient in the patient voice. When patients feel heard, respected, and there is a level of transparency, trust improves greatly with their providers and the overall healthcare system, and care satisfaction also goes up. Patient engagement and participation in work groups and reviews with ICHOM. It's great to see, and it's a win-win. This approach really can help shape current as well as future sets, but it's also a great way for patients to network and collaborate with other patients who share in their journey, other organizations, as well as experts from around the world. ICHOM's frameworks and standards will also help inform and shape treatment guidelines, policies, and regulations that can further promote patient-centric care delivery and value-based healthcare. As healthcare evolves, there are also very many areas that we need to expand our thinking in, and I'm happy to say that ICHOM is doing much of this already. When utilizing the patient voice in healthcare and in developing sets, we need to make sure that we are mindful to include the involvement that represents both a diverse and an inclusive patient population. Measurements need to be sensitive to both cultural differences as well as being relatable to various socioeconomic contexts. We need to ensure that specific and unique patient populations are also reflected. And another voice that oftentimes is forgotten is the voice of the caregiver. And this extends past the pediatric population. Caregivers have a unique lived experience, challenges, and barriers that they also face, and they need to be reflected in all sets and all developments within the healthcare system. I appreciate how ICHOM really recognizes the impact of SCOH on the patient outcomes, and I encourage them to continue doing this with developing sets and calling out specific barriers to care, such as access to care and environmental and community factors that also have a great impact on someone's care. And I can't say enough about the importance of mental health care. And while it's reflected in many of the current sets out there, we need to ensure that we have a comprehensive approach in integrating mental health care and well-being across all medical conditions that we look at. And then finally, I can't help but wonder how the addition and the call out of preventative interventions, as well as holistic healthcare, could further complement the treatment outcomes for patients and broaden the scope of ICHOM's work and ensure even better patient-centered care. We must see patients as partners throughout the whole entire healthcare system. Patients are the consumer, and we need to make sure that they are the center of the model, anything that we create within our systems. Thank you again for letting me briefly share some of my thoughts around patients and their involvement in healthcare. And now I would like to introduce Amanda Casey, who is the department head and associate professor with NS Health. I'm sorry, Amanda.
Thank you so much for the time. if we go to my next slide, you'll see that I bring a few different perspectives. I will speak a little bit about our local institutional perspective as a radiation oncologist and head of that department implementing a patient outcomes program. But first, I wanted to start with national perspective. I am chair of the Pan-Canadian Radiotherapy Electronic Pro Initiative and have some perspective on that landscape over the past decade. On to the next. So first, sitting as a committee member on the Big Data Subcommittee of the AAPM, I've been fortunate to contribute to our most recent oncology data standards that have been inclusive of PROs. And you'll see in the publication, when the recommendations came out for stepwise implementation, PROs, we were successful to advocate that they are prioritized alongside healthcare provider rated toxicities. Next. Now, patient outcomes have been identified as key quality indicators of radiotherapy programs for over a decade. This was included in our seminal guidance document from the Canadian Partnership for Quality Radiotherapy. And as of 2017, these key quality indicators, patient outcomes, these are embedded into Accreditation Canada standards for oncology programs in Canada. Now, the challenge, of course, is that just because it's mandated does not mean centers can do it, unfortunately. So we knew from our Pan-Canadian Pro initiative that a lot of the challenges faced by local centers were shared. They're common. Thankfully, the guidance documents, Accreditation Canada, set Pro as a priority, that it's for clinical care. It is not just about research. It's also one thing to have the standards, thank goodness for those coming from ICHOM and others in terms of measures to use and when, but you need the buy-in at various levels of the health system in order to move beyond healthcare provider assessment of toxicity. You do need the action plans for the healthcare team, how to deal with the issues identified. We need to look at novel ways of using PROs remotely and the digital tools to do that. But from a basic level, a lot of cancer centers in Canada lack the electronic infrastructure for PRO collection. So if we look to the next slide as to how to address that, first, it's recognizing that there are disparities across centers and regions in our country, and I'm sure others, in terms of the resource and the experience needed to implement and expand patient outcome programs. Thankfully, the Canadian Partnership Against Cancer, the Canadian Cancer Society, they've recognized this in their Pan-Canadian Cancer Data Strategy. They've prioritized patient-reported outcomes, and thankfully through this, there is funding for jurisdictions and centers that want to implement PRO programs and expand their programs that have already been in place. So if we look to our own department, it is because of this CPAC support that we were successful in acquiring NUNA, which is Varian's patient engagement application. And in 2021, we launched, as part of this small initiative, PROs, ePROs, across all of our Dalhousie Department of Radiation Oncology centers in the provinces of New Brunswick and Nova Scotia. So if we look to the next slide as to what came next in the province of Nova Scotia, we expanded even further the digital tools, now connecting across the multidisciplinary cancer care program, having an oncology-specific EMR area connecting clinicians. We've got the data analytics system at the back end, but at the center is NUNA and the patient voice. If we look to what it took to implement as we go to the next slide, we first need to consider our aim in the Nova Scotia Health Program is for value-based care. We need to use the digital tools given to us to drive a data-driven system for clinical operational decisions to assess and measure patient outcomes at the core. But first and foremost, we need to unite the care teams around the patient need. And so if we look to the next slide at the points of, what does this mean? What's the challenge in doing that? To my eye, the title of this paper says it all. This is from our Pan-Canadian Radiotherapy Initiative. We are still in centers striving to fill in gaps between clinical practice and standard. And on this slide, you'll see some key lessons that were learned from the jurisdictions and centers that partnered under that CPAC Pan-Canadian initiative. We need to identify the ways to use technology. We need the strategy, the sustainability plans, but in the end, it does come down to people a lot of the time. The healthcare team, of course, getting the buy-in, ensuring stakeholder engagement. We can't underestimate how much change management is needed in cancer care programs to change the way we've done things for so long and to put the patient voice at the center. So in the end, it comes down to we need that alignment of providers with the philosophy and intent of program co-creation with patients and the public. So on I think my last slide, I say, we in Nova Scotia Health always had those frontline champions ready to advance patient outcomes in a program, but it was through the Oncology Transformation Project that we received the investment in human resource as well as the electronic infrastructure. So first of all, having designated roles, pro-clinical leads, for example, strengthening committees, those for patient-reported outcome. But the last point I'll make, and certainly it's the most important, I would say, of the entire point, we need meaningful patient engagement at each level. Inclusion in the committees, making the decisions from strategic planning to implementation. And I think that segues into what we'll discuss next in the panel, I'm hoping.
Thank you so much to all of our panelists. Your unique perspectives that you brought in your overview talk is very poignant. I think just reflecting on some of the comments from each of our perspectives, Kevin, obviously, from your perspective, the voice of the caregiver, the different levels of engagement that are required, both from a strategic industry partner, at ICHOM itself, your perspective with lived experience, and then of course, Dr. Casey providing an excellent jurisdiction example within the cancer care domain and the very important clinician perspective. I'd like to kick us off, just something that jumped out at me. Kevin, I'm going to direct this question over to you. What is the cost or the trade-off of not including the patient voice or the caregiver voice, which you so poignantly pointed out, in the development of patient-reported measurement or any level of programming that we're striving for across the health systems?
Sure. I think by not really involving the patients, we're missing a great deal of what they experience with their disease state. 80% of someone's healthcare is really determined outside of a hospital or outside of a clinic. And so we need to really make sure that we represent what is happening outside those hospital walls. For me specifically, I can say, as a sickle cell patient, when I get sick and I have a pain crisis and I go to the ER, I'm seen as a patient that's very difficult to treat, to manage. They don't see me as a person living my life outside the hospital. They don't see me doing daily activities, and they don't see the importance of my life, of those activities. And I think, unfortunately, so much of that is missed if we don't involve the patients, because they can really provide insight to so much that physicians and providers don't always see. And, that's important for them to manage their disease and live their life effectively and be contributing members of society. So I just think that there is so much that's missed when we don't involve patients at the very beginning.
And thank you again for your very thoughtful feedback. I think even just watching the comments come in, your patient and lived experience perspective is what connects all of our panelists, what connects probably all of us on the call here today. I'd like to kind of maybe Dr. Casey and Umanga, clinician engagement is extremely important, and having guidelines are extremely important, as your talk pointed out, and all of the work that you've done, Dr. Casey, at the national level to help promote the importance of co-development patient engagement across the country. And Umanga, you touched on the patient charter. What I may put to both of you, and maybe Umanga first, is how are you going to live and breathe the values of engagement and bring that charter to life? And then Dr. Casey, maybe you could follow up with, from a guidelines perspective, how do we actually bring that to life at the coalface, if you will, within the clinical settings?
Yeah, thank you, Leslie. So I think for the patient charter, what we really started off with is looking at our existing procedures of how we currently engage with patients. And we look to really articulate that in a document. And ICHOM really has, from our inception, been focused on patient centricity. So we really wanted to make sure that we clearly communicated that to our community. And now I think what we really want to focus on is integrating all of those principles across the entire organization, and making sure that structurally that we're really focusing on every single one of those points that we've mentioned. So for one of the examples that I can list here is that ICHOM will not proceed with our working groups for sets unless we have at least 20% of patient representatives, all of whom will be compensated to reduce any barriers to participation, and that all patients are welcome and will be provided with the resources to ensure their confidence in participating in these efforts. And so those are things that we've always continued to do and have done and will continue to do. And we really just want to make sure that that's clear to all of our patients and that we are a trusted partner for them to work with as we look to improve patient care globally. So I would just start there, and I wonder if anyone else has anything to add.
Yeah, Dr. Casey, maybe over to you for bringing to life a vision, recommendations, pan-Canadian guidelines. A lot of that was highlighted in your talk, and those are all very important cornerstones to bringing this to life. But then how do we actually make that real?
Yeah, I'll be upfront. I think I was naive in my early career as I thought, oh, we just need the electronic infrastructure. We just need the guidance on what pro measures to use. But we have a lot of that now. And I think what we need is alignment of the healthcare teams with the patients to turn this into a reality. If I look where we are right now, we know we need to introduce pro measures at certain time points into the clinic. But what fits for a care team in terms of, let's say, a care path, as we use in our terminology, may not fit for patient need. How often do they need their voice at the center of this? And this is where we need to engage those patients in the committees making the decisions. And if I take it one step further, I loved Kevin's point about this is about diversity in patient populations as well. We're focusing on how patient outcome assessment may help our remote populations in the rural regions to reach out to them in ways we haven't been able to before. But then we need to consider disparities in access to technology, for example, and how we help overcome that, and consider what challenges people may have in everything from literacy to technology availability, you name it. And that's where all of that diverse perspective comes in.
Very insightful from both of you in terms of making, turning documents that employed engagement, bringing them to life. I wonder, Kevin, from your perspective, what's the skill set that a patient or an advisor or a caregiver, someone with lived experience, needs to meaningfully engage, for example, in patient-reported outcome development, but really in any level of patient engagement from your perspective?
Sure. Specific skill sets, I don't know, that they really need anything other than the willingness to share their story, their lived experience, and how their condition impacts them outside the hospital. have heard some comments in the past about involving patients and, that the education level and the clinical understanding is not there. And so how much information can they really provide? And I think that we need to not look at it that way. We need to see patients individually. We need to recognize their lived experience. And we also need to make sure that we are inviting to patients so that they do open up and share their story wholeheartedly, and make sure that they don't feel intimidated, and that they have value in their feedback. And one way to make sure that they see that they have value is transparency and a feedback loop to where they can come back and see how their feedback was actually implemented and is part of whatever is being developed. And so I think that just will help develop even more trust within the patient population. One other last thing is I would caution, with utilizing patient advocacy groups and things, what I have seen in the past, when we have requests, that we really do a strong search to make sure that all patient types are represented, not just the patient advocates that are most vocal already in the healthcare system, but we have real life experience from patients that may not be as engaged in the healthcare system already, but have reached out to organizations for assistance or attended some kind of event. We want to make sure that we capture their perspective as well, because patient advocates that are truly engaged and actually involved with the healthcare system may have a different understanding of healthcare and their disease management, and it may not trickle down to the true community feeling.
Certainly. I couldn't agree more. I want to pick up on one thread that you mentioned, and that was the word trust. I think that is, I've done a bit of research in that topic, in that space, and trust in an organization, trust in our clinicians from a patient perspective is a deep modifier on many levels of engagement for patients in terms of their ability to, for decision making, feeling empowered to be a participant in their care. So that word trust is just such an important enabler. I'm going to flip the conversation slightly. I imagine many, and we have great participation on this webinar series and today's webinar as well. It's fantastic to see. And I'm going to make a bold assumption. I'm assuming that most people tuning in today are bought into the concept of patient engagement, of delivering a person-centered health system, no matter what disease domain or area of the healthcare system that you're working in. And yet we still see barriers to implementation. We have so many allies in this space within organizations. Dr. Casey, you mentioned a lot of this comes down to people. Kevin, your note around trust is so important. Transparency and trust, cannot underline or emphasize that enough. So to the panelists, all of you, and we can potentially start with Dr. Casey here. What are some of the barriers that you're seeing in terms of patient engagement and patient-reported outcome implementation in your health system?
I'd put it twofold. So one is, I think we lack resource. A lot of the time we're very stretched and we're just trying to do the best we can do. And with that lack of resource, you don't have the structure that needs to be in place to support something like this, that needs true strategy, sustainability. Patient outcome programs are extremely complex and deserve all of that extensive patient engagement, but also healthcare provider engagement. That how do you get those frontline staff engaged when they just feel like they're drowning? And so that's I'd say one piece, which seems a bit negative, but I'd go to the positive. We are finally getting some of those resources in. And then so once you get the resource and you get your health authority and et cetera listening, and you start to build that structure, I think part of it comes to helping the healthcare team understand how they can meaningfully engage with patients and public. I loved, again, some of the comments before. You certainly don't want to put a patient or public representative at a table of 20 others, not understanding the conversation, feeling very outnumbered. How do you build trust in those settings that they're equal partners at the table? There's a lot now we need to do to learn in our system to have everyone as equal partners at those tables. Not that we don't want to, we just need to learn more from Kevin and all of how to do that.
Any additional comments from Kevin or Mongo?
No, I would just agree with Amanda about the resources. And I would also add, I've been involved with some patient and family advisory councils at the hospital where I get my care. And it comes down to a lot of a culture shift for systems. Fortunately, my hospital has been very, very open to the PFAC. And, now that we are seeing more emphasis being put on SDOH and outcomes being involved with payment models, healthcare is actually a business, and we are now impacting the bottom dollar. And so I think that is helping to help organizations accept and make a culture shift where patients are more at the center of the discussions and trying to figure out how we can actually improve patient experience within the hospital. So, I would just add that to Amanda's comments as well.
Thank you. Mongo, I see you came off mute. Please go ahead.
Yeah, I just want to make a quick comment that I think that patient engagement in those contexts is really important to make sure that it's done authentically. So I think in a lot of contexts, patient involvement is used in a one-off setting instead of patients being integrated throughout the entire process and made to feel like their perspectives and voices are actually heard and that they actually matter throughout the process. So I think that's something that's really key to take into account.
Yes, I mean, true authenticity and transparency builds that trust. And then it's that feedback loop where you have that longitudinal engagement across initiatives, across the organization's culture. And that's where you get that positive reinforcement and you get to that true and meaningful, purposeful engagement. And the buy-in then comes for future initiatives as well. Perhaps I'll check in with the ICHOM team, trying to watch some of the questions and comments coming through to start the panel off with some of those questions. But are there direct questions that the ICHOM team has pulled forward that we might want to pose to all of us on the panel?
Hi, Leslie. Yeah, we have a couple good questions. There's actually been a lot of questions with some overlap, so I'm going to do my best to direct them to the relevant people. But if someone else has something else to add, please chime in. So the first one was directed at Leslie. So in regard to Varian, could you just speak a little bit more about how you directly collaborate with patients? And in that regard, how do you recruit these patients and bring them into that process?
Fantastic question. Yes, being a technology and innovation company that is not patient-facing directly, we rely on working with industry and hospital partners to be able to do some of that work to ensure that we are living and breathing what we have said from a patient partnership perspective. So that's an excellent question because we are very far removed. And having led a hospital system for many years, I thought, or I was nervous that I would move to a big organization, a big enterprise or a global organization, and that wouldn't have that opportunity. But that is just certainly not the case. We work both from a traditional model in terms of our clinical research to embed patient feedback into our technology development pipeline, our innovation pipeline. We fund a lot of research globally with our clinician scientists to enable engagement at that level from a research perspective to make sure that we are staying relevant from on a clinical scale, that patient engagement. But more importantly, like an example, like our system, like NUNA, we have a patient advisory committee that we work with to make sure that we're constantly updating the features and functionalities in that tool. Just one example, where it is relevant from a patient perspective. I'll give you a very specific example. So patient messaging is pretty controversial. There are many portals in the big EMRs, EHRs in the world where there is patient messaging enabled, and it's enabled in our Nuna system as well. The challenge is, and it goes back to some of Dr. Casey and Kevin's points, is that the clinician receptor and buy-in needs to be there as well. And so when we build out patient messaging in our system, the patient feedback that we were receiving on Nuna was to also ensure that maybe if there isn't that level of buy-in yet, we have to be realistic. Not everybody's there yet. That we needed a diary function within our system so that patients could at least capture all those questions. As Kevin noted, patients live with their disease and with their treatment 24/7. They may be interacting with that healthcare team for a 15-minute snippet on their follow-up appointments. That 24/7 is where all of that questions, uncertainty, not knowing the next steps in their care, etc., are coming up. And if patient messaging hasn't been enabled yet, we'll get people there, I know we will, for that buy-in, then the diary function was something that was extremely important to patients so that they could track how they were feeling when they were living with their condition or their disease or their treatment pathway 24/7. So just utilizing patient engagement, both from a research perspective, a clinician engagement perspective, but then also actually advising on features and functionalities. So though we're not patient facing directly as an organization, we do make sure that we bring that philosophy and ethos to light in all of our product and service development and implementation. So thank you for that question. Excellent.
And I do want to add, I think I see Amanda's hand up, so I want to see what she has to add to that.
Yeah, just a quick comment. Leslie, you didn't mention the professional services that Varian provides with some of these digital tools. I think that is invaluable. You know, it's one thing to help a center to launch a digital tool, but the expertise that Varian provides, you know, what are other centers doing for patient engagement, for their pro programs, how they use the tool so that centers can overcome their jitters and move beyond by learning what others do. So it speaks to that power of community of practice, that if centers can somehow learn from each other, we'll be able to overcome the hurdles. And Varian is a critical link in this right now, given Nuna and your experience of what other centers are doing for patient engagement.
Thank you. Thank you for reminding me that. Sometimes when you're in it, you forget all the important aspects. Thank you.
Yeah, on something you mentioned about constantly reflecting, updating. I think that transitions naturally into another question. This one is going to be directed at Umanga. The question states, core outcome sets, including those developed by ICHOM and others, can often contain large numbers of outcomes, so a lot of different variables. What work is being done at ICHOM currently to assess the burden and acceptability of the measurement among patients in practice? So rather than the hypothetical, how are we actually making these sets clinically feasible?
Yeah, of course, that's a great question. So we fully recognize that even though the ICHOM sets are supposed to be minimum recommendations, and when we do include the outcomes, they are indeed a very small selection out of the entire list of outcomes that we do consider, that there are still enough for this to potentially be burdensome to both the patients and the providers. And so when we go through, once the sets have been launched and we have a system and process in place a few years down the line where we have a set update process. And so there our goal is to bring together members of the former working group, as well as implementers and new patient representatives and people who are actively implementing, get their feedback on whether the set is potentially burdensome. And the patient feedback here is also very important and taken into account as we look into whether any set updates are needed. And so that's something that we actively will be doing for all of our sets going forward once they've been implemented. Additionally, we are also developing primary subsets for all of our sets. And so this is just a kind of condensed version or smaller version of the sets that have been launched, really looking to recommend a very core set of outcomes and measures that will be a starting point, especially for implementers that are perhaps new to outcomes measurement, and that they can use to kind of get familiar with the implementation process.
One thing, if I may, Spencer, is add to that a very important point. I've been in this space trying to implement prompts systematically for a long time now. I don't even want to say how many years, but a really important piece to that, this concept of a burden on the patients, we have to recognize that if the clinical team is not acknowledging the time and response, the time the patient took or the caregiver took to respond, and their actual responses in that clinical setting, whether it's in an appointment or with a telephone follow-up phone call or a virtual assessment, some way, even an electronic reply that is meaningful, that adds more significantly, and there's been some work out of the NHS that has looked at this, that adds more significantly to the patient drop-off rate of their engagement in their care than the actual length or number of questions that we put on a patient. So I don't want to minimize or discount that there is, patients, especially in our world, in cancer care, are fatigued, maybe in severe pain, are feeling very unwell for many reasons, but there's a willingness from patients to put that effort in, or have a caregiver help them put that effort in if their responses are acknowledged and acted upon. So 2 steps, and we've looked at that in many jurisdictions across Canada. Okay, patients filled out their patient-reported outcomes and their questionnaires, but was it acknowledged by a care team member? No matter what mode or method that is, electronic or face-to-face, or even just with an electronic response, and was it actioned upon if appropriate? And that helps decrease the burden from a questionnaire or survey fatigue, if you will. And that's been studied. And so I think we all need to remember that important piece. We can shorten questionnaires. We can revalidate, clinically appropriate shortened questionnaires. But really, it comes down, in my experience anyways, it comes down to that care team acknowledgement. I don't know, Kevin, I do see you nodding. I assume you're in agreement with that, but maybe your patient experience would be really important on that.
No, I completely agree with what you said. And it goes back to my comments earlier that patients need to feel respected and heard and acted upon, when their feedback is listened to and actually they see how it's been implemented or responded to. They see value in that. But if it goes unanswered or it's not really heard or listened to or addressed later, that trust level, again, especially in my community with sickle cell, there's a huge trust barrier that exists. And, that's one thing I see with, our healthcare providers in our community is they have to develop that relationship and that understanding with patients and work on developing that trust level. And part of that is how they respond to what patients are telling them. And so I couldn't agree more with you.
Yeah, that's a fantastic point. And I think something that resonates with me from the previous ICHOM conference was the fact that we are all patients. So if someone asks you a question and then you answer and then they do nothing with that information, that's annoying. That's a burden. Like, why did you ask that? So that's something that I try to keep in the back of my mind as well when thinking about developing these sets to begin with. If we're asking these questions, they have to be actionable. They have to contribute something to that process. On that topic, this is a question not I might handle this one because it's kind of vague right now, but it is something we are going to follow up in after this call. But the question is, can you share specific examples where patient co-creation has led to significantly improved health outcomes? And the short answer is yes. On the ICHOM website, we have a whole section dedicated to some case studies from various countries, various resource settings. And in these case studies, they utilize ICHOM sets, either in their entirety or in some capacity, and illustrate the how you can take it a step beyond the original, the typical clinical, we're measuring mortality and adverse events and stuff like that, but go beyond that. So the ones I want to highlight, well, the one that's on our website currently and the one that will be on our website, the one that's currently on there is the Martini Clinic case study in Germany, looking at prostate cancer patients. Instead of looking at just mortality rates of those patients, they also look at sexual function or erectile dysfunction and urinary incontinence, and really focusing on those things and not on mortality. Mortality across all hospitals is basically the same, but focusing on those things, this Martini Clinic does it better than anybody else in Germany, probably anywhere in the world, by focusing on the things that matter to people living with that condition. So if you're not even asking them about their sexual function or their urinary incontinence, then you're totally, as a clinician, as a provider, you're totally just missing the ball. The other case study, this is a little foreshadow tease, if you will, for the next month or so, but we are going to be releasing a case study from Mexico that looks at a diabetes clinic that actually captured quality of life and distress related to diabetes. And so focusing on those things, how the disease impacts the patient's lives, not just are they dying or are they living, right? Exploring, it will explore a little bit more those nuanced aspects of people's lives in it. But there is a question I wanted to highlight for Kevin here. Kevin, how can we promote patient focus in a productivity-based organization?
I don't know if they can expand on that a little bit more, or I'm trying to figure out what exactly they're asking that question.
One piece, maybe just to round it out, what I think they might be getting to, Kevin, to give you a springboard, there's often a myth that patient engagement will take longer. And in fact, so I think what they're maybe saying, and if they're not, please, the person who put the question, please clarify if we get this wrong. But I think when health human resources are so strapped, and the clinics are so overburdened in many hospitals, and people are pushed to have more productivity, better capacity utilization, etc., every day with less, do more with less. There's a sense that adding in patient engagement is too big of a lift, and will take more time. But in fact, studies, many studies for decades now, have demonstrated that an engaged patient and having standardized questionnaires actually shortens the visit time. Co-setting the agenda at the beginning of an appointment actually shortens the appointment time. So using validated instruments like the ICHOM sets is a key way to be able to do that. There's been many studies that have looked at how fast a clinician will interrupt a patient before they start asking the questions that are important to them. So if we back it up, and that actually makes the interaction take longer. So if we back it up and use validated instruments, and we co-set an addenda together for how this appointment is going to roll out, you can actually speed things up. So I think maybe the question might have been in these very productivity focused organizations and clinics. Well, from a patient perspective, how could that look?
Okay, so I that makes total sense to me now. I do think that we just have to do it, and we will see that schedules and interactions within the healthcare system will improve. And, you know, if we can't do it within our current metrics and how we run the office and stuff, we need to think of different creative ways to engage the patient population outside that clinic visit to maybe get some feedback from them on how we can, you know, use their information in future visits as well. But as a patient and seeing the value of my voice being heard by my providers, you know, I hate to say it this way, but I don't care as a patient that you've got X number of people that you have to see this hour. You know, my time that I book is about me, and I need to be able to get my questions answered and get my experience reflected to you. And I think over time it will work out to where it may actually free up more time because you have less people coming in to have their problems addressed because they're actively managing them outside the hospital.
Outside the hospital, or they're not calling in because they weren't given the time. And so then you need a whole structure to respond to the telephone calls and the additional messages. Like there's just so many ways I can see, Kevin, that it would actually speed things up. And we do have validated, you know, studies that have demonstrated that. I don't know, Spencer, if I know we're getting close to time when we have a wrap up. Do we have maybe time for one more question to the group?
There are a bunch of questions that I think are better suited offline. This might be a good time to wrap it up because a lot of the questions I'm seeing are kind of like doubles of kind of stuff we've already talked about at this time.
That's great. So I just want to give a very huge thank you to ICHOM for selecting this multi-perspective panel on this extremely important topic. I think, you know, getting us back to the basics, especially after the global impact that the pandemic had on patient engagement, I think is very important. I know last year as I attended the ICHOM conference, that was a theme that people felt that had set the globe back in this space. And so I think ICHOM taking a leadership role in ensuring that we are you know, getting back to the basics, setting the expectations around co-creation, co-development for truly person-centered healthcare systems across the world. I think I just want to thank you very much for your leadership in that. And most importantly to the panelists, Kevin, Dr. Casey, Umaga, for taking the time to give your perspectives, so important. And maybe if I can just summarize to the group, you know, the theme throughout is authenticity, is transparency. If you don't know how to do this, that's okay. Patients will come along with you. Patients will help you along the journey. It's, again, another panelist comments, I believe Dr. Casey says, you got to take that first step and have the courage to do so in an authentic manner. So with that, I will turn it over to Jennifer, the ICHOM president, for summing up the webinar. Thank you very much.
Wow, I'm an ambitious person, and this is one of my favorite topics as a lifelong patient advocate, both for myself, my family, and for others that have historically lacked a voice. This just exceeded my expectations. I just want to say thank you to Leslie, Amanda, Kevin, Umaga for this wonderfully rich conversation, and to Spencer as well for wrangling the back end. I also want to thank the entire audience. You have really been very engaged in the chat and challenged us with some really important questions. And of course, one of the limitations always of a webinar is that we can't get to everything. But as Leslie noted, and Spencer as well, there's a number of questions and follow-up, both with individuals and organizations that I know that we will be pursuing in the coming days. I hope that for all of you who are listening, whether you're joining us today or you're watching this after the fact, that one of the things you walk away with is the fact that ICHOM has historically and continues to be a community of practice and of learning about how we can co-create the future with patients, with people with lived experience, with caregivers, with families, to envision the true backbone of what we should be doing in healthcare and the data that we need to have in front of all of us to make good decisions for health and for good life quality. And that is about measuring patient-centered outcomes. That is the mission of this organization. And I hope you're walking away with the notion that we are a very energized and well-timed community of practice, and that we want to continue to expand our working relationship with organizations like Varian, with clinical leaders like Amanda, with patients, patient leaders, patient organizations like Kevin, like those that are joining our Patient Partner Alliance. So this is a very, very important part of our mission as an organization. And it was our objective today to share that journey with you and to welcome your insights and ideas to help keep us on our toes. So with that, I just want to share a couple of things that are immediately ahead of us. Umanga helpfully teed up the notion of our conference that is happening October 21st and 22nd in Amsterdam. And I wanted to share some things because it was a personal ambition of mine to make sure that we were living, to one of the earlier questions, that we were really living our truth and ensuring that we were expanding our community of people able to attend, that we expanded their voice on our advisory group that helped us put the agenda together, that we ensure that there's ample patient perspective in every one of our sessions, or as many as we can, and that we are continuing to expand our capacity to support that through things like scholarships, through things like making sure that we can engage in the planning. And also, I'm very excited that we will be announcing very soon some expanded site visits, some of which are really focused on our patient communities and empowering them both to understand advocacy as well as the science around outcomes measurement. And the last thing I will share with you, there were a couple of questions about data collection and the challenges. We want to always focus on the positive, and certainly ICHOM, through our case studies and other work, we're really trying to emphasize the positive impact of outcomes measurement in concert with things that are meaningful to patients. But one of our next webinar in this series is going to focus on what are some of the barriers and things we're doing to take those barriers out of our way when we talk specifically about data collection. We're in the process of finalizing our speakers. That will be forthcoming, but please do go to the webinar series site to register for that webinar, which will be on the 5th of September. So with that, thank you so much for your time and attention. Thank you for the energy that you bring, and please stay in conversation with us. We welcome it. Have a great day.